So I wanted to say basically a little bit about why we chose to do this evening. So we felt that often in Adolescent Health Weeks you get a lot of information, and a lot of it is really useful around how to speak with young people and how to do different things. And hopefully some of you have been able to join Steph Lamb's chat this afternoon, which went through really beautifully the kind of assessment of an adolescent or young person that you might come across. If there are one kind of thing that we don't do very often with Adolescent Health Weeks is teach you about a lot of the common things that you might see on the day-to-day in the wards. So this is what we hope tonight will do. I was asked to just make sure, because I did this week with Najette and Emma Sunderland, so two Emmas to remember there, but we created this week and we were asked really to make sure that you fill it in, not just because we want feedback on speakers particularly, but also on kind of the content and what you wanted to get out of the sessions is really helpful. There's a couple of resources here, the YIPSIG app, which is a good app for doing the heads assessment, as well as some additional learning weeks that we've got coming up that link and dovetail nicely into the one today and this whole week that you've been having. And do think about joining YIPSIG, which is the Young People's Health Special Interest Group associated with the Royal College of Paediatrics and Child Health. It's open to anyone that works with young people, not just to trainees, but there is a trainee rate, and you get a little bit more information sort of streamlined to you about opportunities that might come out. We also have a trainee committee within that, so it's something really worth thinking about if this is something that you felt inspired from this week or you already knew was of an interest to you. So what we're going to talk about this evening around common presentations is really what's so different about adolescent health anyway. Why is it labelled? Why is there a distinct kind of week about it? And it's really a thing very close to my heart, because this is an area of medicine that I got interested in during my paediatric training. I'm now a general paediatric consultant at the Evelina, but I've worked in lots of centres across London that have an adolescent health slant, so at UCLH and their adolescent health units, as well as some feeding and eating disorders groups and some specialist safeguarding. So I think it really embodies a fantastic group of patients that you come into contact with. What I'd like you to do, just while people are still kind of filtering in, is just have a little bit of a think about what does the phrase or the term adolescence and adolescent health mean to you, and perhaps pop it into the chat. What kind of images does it evoke? What are maybe some of the things that you want to get out of the session today? And it'd be really helpful, because if I'm going to cover it, we know we're in the right direction. And if there's something specific that you pop into the chat that you want to see, or why you've signed in, why is this useful for you? What would make it worth your while having signed into this seminar to feel comfortable about by the end of it? So we've got, yeah, so Ruth's talking about some preventative health. Yeah, we can talk a bit about that. Any other things that you think about in this age group, or the thoughts that go through your head when someone says there's a 15-year-old on the ward and we need somebody to go and clerk them in? While people are filling in that chat, part of the reason I asked that question about what is it useful for you to get out of the session is that that's often how I open my clinical consultations with young people, is thinking about what is it that has brought them to see me, and kind of giving them some control over what they want to hear about during the consultation. So if there's something burning that you want to find out, pop it in the chat and I'll keep an eye on it. What we're going to go through this evening is adolescence and development, a little bit about communication tools, although you've had some of that this afternoon if you managed to join that talk, and then some case discussions and some resources. And really, if there's one thing that you take away from the session tonight, what I would really love you to get out of it are lots of things, but if there's only one thing you take away, is that adolescence is really distinct from childhood and adulthood. There are specific things that you need to equip yourself with as a paediatrician, but not just as that, as anyone who works in healthcare, because you will come into contact with these young people and their families. This is the kind of media of adolescence. So these are the kind of things that spring to mind generally, probably giving away a lot of my age on these references. But there's a lot of kind of a bit dirty, a bit awkward, a little bit of a tricky time, with lots of kind of exploration and peer group discussions and things. So that's the kind of media portrayal. What I'd like you to think about maybe are some of these young people. Does anybody know who anybody is? You can pop it into the chat for a little bit of a pop quiz. Who are these people in these images and why might I have included them? I'll give you a second to have a look. Or you can shout out if you prefer. Malala, yep. Ellie Simmons, Greta. Anyone else? Phelps, yes. Ritu, well done. Not many people have gotten that one when I've done this before. Got Coco from tennis. Got Andy Murray, has to be in there because he's one of my fellow Scots with Rafa Nadal. Billie Eilish and Adele, yeah. So the reason I've included these people is I think they've all achieved something during the period that we would traditionally consider adolescence. And I don't think you look at these images and you think of a child. You've probably seen someone who's making some form of contribution. And many of them have done that at a really young age. So Phelps was in the Olympics in his teenage years. Andy Murray, Rafa Nadal went into professional tennis at 17. Billie Eilish is one of the youngest singers of a Bond theme song. Coco, 15 when she went into the professional circuit, and Adele, world-renowned artist who wrote very famously a lot of her work when she was 18, 21, so named her albums after those definitive times. So I think it's about realising the potential of the young people you're going to come into contact with and who you might be treating and managing at different extremes. So we know there are different definitions, and there's been a little bit of a debate about what classifies as paediatrics, what's adult health, who goes where in A&E. But really, adolescence is this defined period of childhood before adulthood, and the WHO defines that as kind of up to 19. But then youth from the United Nations is defined much more broadly, from 15 to 20. Sorry, I don't know what happened there. From 15 to 24, and then you've got your young people definition in the UK. Generally, what we describe it as is between the ages of 10 and 24. So taking in that puberty and those periods of development that Hung Wei was talking about to us earlier in the week, and then right up into kind of your adult patients that many of us in paediatrics don't really get to see unless we're doing specialist services. I want to ask you a little bit about either thinking back to your own adolescence or thinking about the people that you're looking after now. What are the key developmental stages of adolescence? What are people going through that get them to the point of becoming child adult? I don't mind if you want to volunteer with some shout-ins or if you just want to write into the chat, but what are the kind of things that you notice happening in adolescence? What's the developmental stages? Puberty, absolutely. Moving away from parents in terms of growing independence. So yeah, getting that sense of identity, sense of self, becoming independent. Any other changes that happen? Friendships, yeah. So moving from kind of parents into peer groups, it's really important for us understanding about health promotion, health prevention. There are a few others. Yeah, social maturation, developing that kind of abstract thinking, and education is a huge developmental point. So you move from being someone who's quite well protected in a kind of primary school environment through to someone who may be doing further education or even employment. So it's a really important time of development. Brilliant. You guys have gotten most of them, I think. So there's this physical change. You know, it's this kind of second biggest physical change we go through. So in that first year of being 0 to 1 as a baby and into being an infant, you have this massive growth spurt, triple your size, triple your weight. And then in adolescence, we do this the same. We have this pre-pubertal growth spurt, or in girls, this kind of more elongated growth spurt. And then there's the sexual maturation, social and economic independence that many of you mentioned, that development of identity in your relationships, and this abstract reasoning. And one of the things, the reason for kind of going over this before we go into the case reports, is that I really want people to appreciate adolescence in a similar way to how we appreciate that younger child development. So we are all familiar in paediatric training, get told all the time about the developmental milestones, understanding what children are doing at different stages in their gross motor, fine motor and vision, social development, language development. But we don't really have the same concept around it for adolescents. And if you've not watched it before and you've not seen this TED Talk, by Sarah Jane Blakemore, it's brilliant. It's 14 minutes. It's available either through that link or just Googling the TED Talk. And it really explains how the adolescent brain develops and why adolescents might come from things at a different point of view from someone who's already gone through that development. And some of the key take-home messages are that really your brain develops into your 20s and 30s. We used to think it was kind of static, and now it develops. And much of it is to do with the synaptic pruning that happens, this kind of really honing in of the things that you need to keep going with in your adult life. And that's quite an energy draining situation to be in. If you think about that kind of developmental progression, having all of this going on means that a lot's happening in a short space of time. And the other thing that we know is that this prefrontal cortex activity decreases during puberty, and that's where we know from lots of our sorry, I don't know why it keeps doing that, but we know that from this kind of social development that the prefrontal cortex is a lot of the responsibility for your personality, your ability to reason and empathize. So that's changing at the same time as you're developing all these behavioral tasks and perspective. And then your limbic system, which those of you might remember is kind of your feedback loop for positive stimulation, is really hypersensitive. So you're getting all of this reinforcement at a time when you're not really got the decision-making capabilities of weighing things up and seeing things literally from someone else's point of view. So for those of you that either are living with teenage children, or have kind of cast your mind back, it's really hard for them to understand, and they kind of go from this very compliant and interesting young sort of child as they grow up into kind of sometimes quite a hard to understand young person. So, but we are really understanding of that when somebody's 2 and we know that they're going through development and they're testing boundaries and they want to check how they're doing that, and they have a complete meltdown in the supermarket. People understand the terrible 2s. But when it comes to understanding that in adolescence, you're wanting to do all of that exploration, all of that self-development at the same time as going through huge changes physiologically, we're not quite as understanding as we could be, probably. And then bringing it back to you, you know, as a trainee or as a health professional, why should you be interested in adolescence and this period and educating yourself a bit more? Well, it is part of your curriculum. There are GMC expectations, but really these young people and their families are going to be coming to you with their issues and hoping that you can understand what they're going through in a bit more detail and helping them. And you will see young people in every aspect of healthcare. I promise, whichever aspect of paediatrics you go into, or if you're an adult physician or a GP or working in any kind of setting, then you will come into contact with somebody between the ages of 10 and 24, I'm pretty sure. So we've labelled this as common presentations, and that's what we want to get onto. I think there are a number of evolving issues, and some of you brought up wanting to think about preventative healthcare. we know that chronic health conditions and comorbidities are increasing as we're getting better at treating childhood conditions, as we're having more children born prematurely who have multiple health conditions. We're seeing that go into adulthood in a way that we maybe hadn't done in the past. And that comes with its own challenges. We know that obesity is caused with this kind of second pandemic, and that in the UK in particular, we really got a big problem to overcome in this field, and that's something we'll talk about a little bit later, and I know that Steph also talked about it earlier today. Mental health and sleep, well, I don't think we needed a pandemic to raise our awareness of this, but it has sort of brought to head in the fore quite a lot of concern around people's well-being, and we know that in adolescence your sleep goes through multiple changes. And then there are some kind of very specific conditions that tend to present in and around adolescence, not only mental health conditions that we know present in that time frame, but things like chronic fatigue syndrome that's much more common in the adolescent age group, eating disorders, and then things that we tend to maybe not think about and ignore a little bit when we're dealing with acute health problems, but things that can be really detrimental and worrisome to young people, acne, sexual health problems, and then all the things that we worry about from our safeguarding hat, thinking about online safety and the increasing in violence and vulnerable young people, which we also had a talk earlier in the week from Dwayne and Jess, which hopefully if you saw that brilliantly, and if you didn't, then it will be available to catch up on. So I just wanted to say a really brief bit about talking and engaging in kind of consultation with young people. Is there anybody who's joined us? Because I know that you're a self-selecting group potentially who come tonight. Anyone who wants to share any thoughts or worries or kind of issues that you've had around communication with young people in clinic or on the wards or in A&E? I'll give you a minute just to pop something in the chat. Well, people are thinking about that. I'll share some observations that I've had. So I know that it's been a real progression and a way of thinking around how I communicate with young people and having some time with them away from parents. Let's just balancing the conversation with the parent and the child in the same room. So that's interesting because I think we get a lot of talk at the moment around, you know, having the voice of the child and the young person, being able to hear them in the consultation. And sometimes people feel really comfortable and sometimes people don't about seeing young people on their own. But what you're really struggling with in an adolescent consultation often is exactly what you pointed out in that comment, which is really helpful. Thank you, Ritu, about having the family in the same room together and trying to balance where are you having that conversation. So one of the tips that I would give around that is a bit like what I did at the start, asking you what you want out of the session. And I said I ask a lot of young people that at the start, what would be helpful for you? So today I had a young person in clinic that we were able to see face to face, which is quite unusual. We've been doing a lot of virtual clinics. And they came with mum and dad, and he's 15. And I said to him, what makes it worthwhile? You've come all the way to see me. It's not been easy. You know, everybody's in masks and gowns. What would be helpful for you? And then ask the same to the parents, because actually there are two different things, and it's quite helpful to allow them to hear what's the perspective of each other in that room, but always starting my questions and discussions tailored to the young person. So who have you brought with you? This is kind of how I run the clinic, and telling them a little bit about how I like to use the time. So what I tend to do is speak to them together in the room, take the history, often do the examination at that point if it's appropriate, and then see them independently for kind of 5 minutes or so longer if they need it, but in a kind of clinic situation or an A&E situation, probably up to 5 minutes of just kind of going through the kind of social history that we need to get out of it. So that's how I tend to balance that conversation, but really aiming it at the young person themselves. It's really important, I just flag it up now, to have this kind of confidential discussion mentioned and upfront, and asking the young person what they understand by confidentiality is often a really good insight into what they say. So today, for example, I had a really good conversation where the person was able to tell me that it means it's not a secret, but it is just between me and my health professional, versus, you know, a slightly younger child who often thinks that it means that you don't tell anybody. And I'm really clear at the beginning of the conversation that I'm going to ask you some questions that some people find a little bit probing. The reason I'm asking you those are because I am really wanting to help you with your health and make sure you've got the right information about some of these issues that lots of people bring up with me around your age. I'll often say something along the lines of, do you know what confidentiality means? And they'll tell me, and we'll have a bit of a chat about what that means. And I'm really clear that actually, if I don't think I can help you on my own and I need to get help from a colleague, or I'm worried about what you've told me about for you or for the safety of someone else, then I might need to tell somebody else. And I'm really upfront about it. And sometimes saying that with the parent in the room is really helpful because they understand the context of that conversation you're about to have on your own. But really, I've not had anyone say that they didn't want. I've had one family say that they didn't want to leave the room, and we had to find another way of speaking to that young person on their own. But generally, the parents are quite happy for that conversation to happen without them there. You got some discussion. I don't know, you can let me know in the chat how many of you were able to kind of zone in and tune in to Steph's talk earlier today, but I didn't want to go through heads in too much more detail because it's really beautifully done in that talk. What I would say is that if you've not heard of it, or you're not familiar with it, or you're not as comfortable with it, then think about downloading this app, which is from the IPSIG website. It's a free app and it gives you kind of introductions and questions that you can use, and some examples of how to ask open and closed questions in a really helpful way. We know that it's been around since the 90s, but people just generally don't seem to be as familiar with it as you might have expected. And there are other ways. It's just one way of entering into a conversation, an ID building rapport from the kind of easier to ask questions, so home, education, activities, drugs, and then sex, sleep, suicide, and mood is how I use it, but people use it in different ways. The idea is that you start with the questions that are easier to kind of lead into, or a bit more comfortable for you and for the young person, and then you get some of the harder stuff once you've built that bit of rapport. Obviously, it's a kind of developmentally appropriate model, so you use a little bit less in different age groups, but I would really say don't presume. So don't cut off lines of discussion, or don't think I'm not going to ask about that because of their age. You'll be surprised how young or how many of your preconceptions can be from oh, sorry, this keeps bouncing out and I'm not quite sure why. There it goes. Okay, seems to have decided to stop. Yeah, so basically it allows you to think about it, but don't cut off the questions, preempting, because there's nothing worse than kind of having built all of that rapport and then not asking the question because you presumed that it's not going to be relevant to them, and actually it would have been the most relevant question to ask. So do go through it. I always compare it to the newborn examination. We do that in every baby twice. We do it, you know, in the first 72 hours after life, and then again at 6 weeks. And that has a much lower yield of new information than the HEADS assessment, actually, from some of the meta-analysis of use of it. So we know that about 1 in 3 times you use HEADS, you'll find something that maybe needs further action, which also poses a problem, because if we don't have all of the support for that, then what do we do? But basically, it's a really useful tool. And we know that it does make a difference, that before using heads as a sort of standardized format here at Evelina, we had really small numbers of adequate social histories taken, only 3%, and that following kind of initiation and use of this, it's going up and up. This is from a couple of years ago, but the kind of teaching and using the pro forma goes up to 35%, so just over a third of people having a really accepted level of social history taken, which is kind of a bit worrying because it's a good part of, yeah, a really good part of your clinical assessment. It's a big part of what's going on in these young people's lives. And it is helpful for you to do your health promotion advice. If you don't know someone's having sex, then how are you going to do that? How are you going to know to give them the right information? If you don't know that they're feeling low in mood, how are you going to know to be able to help and support? And if you don't know that their sleep's abysmal, then you can't give the information as effectively. So do think about using that in your everyday practice. The tricky bit, and I will agree with everybody that tells me this when I do these talks, is that how do you get it done? When can it happen? And obviously there are lots and lots of barriers to getting it done. So somebody comes in, if you think about it, one of the young people, and I want you just maybe to have a think while I talk through this, about a young person you've seen recently who's come in through A&E into a busy department. They've got an urgent clinical need, I don't know, they've maybe got a DKA, they've come in, it's not really the right time to be asking about all of their school and what are their activities and what do they like. It is possible, but it might not feel naturally the right time. And it's hard to get that space away from family, or, you know, the curtains are not soundproof, even although we pull them round and seem to think they are. So it doesn't quite happen in ED. They get admitted onto the ward, you've got this kind of busy ward round, a bit of a business round. You've got lots of new acute admissions, you've got new teams, so the rapport that's been built up in A&E isn't quite continued into this space. Again, it's a bed space, you're not finding that space around the bed where you can have some chat, and you've got these visitors coming in and it's never really opportune. So then it gets missed there. You're just about to discharge the person, you're doing a beautiful discharge summary, and then you realise we've not done the heads, or we've not really asked about that, but actually we've got limited time to intervene, the family's coming, we need to get the drugs to pharmacy. It doesn't seem like the right time. So somebody, when they come back to outpatients, will definitely go through this. And again, you've got like a late running clinic, you've got really difficult times getting the right kind of space, and the challenges that you've already raised in the chat around getting parents on board with you seeing them on their own. So the ultimate aim is that you wanted to do it at every point, but it's been tricky. I do agree with those challenges, I do acknowledge them, but I think people build up the kind of heads tool as something that is really hard to do. It's not, as you get more used to doing it, it can be really hard if it evokes something and you need to deal with it from the young person, and obviously that will take your time. But I think it's a really worthwhile intervention, and just asking the questions and making people aware it's a space where they can answer them might mean that if they don't disclose something to you that's important, they might disclose it to the next person. And we know that kind of it takes about 7 or 8 discussions for people to feel really comfortable with someone when it's the most precious secret that they have about themselves. So there's a really lovely bit with Emma Sparrow, who's the RCPCH and us patient engagement and liaison officer for RCPCH, and she does this session where she asks you to imagine, and I'm not going to ask you to put this in the chat, but to imagine your worst secret, think about that, and she walks around the room and she says, I'm going to tap someone on the shoulder, and you presume that she's going to come and say, you need to tell your secret. And it's really sort of anxiety producing, because you think, God, she's going to ask me and I'm going to have to try and either not tell this secret or tell everybody and they're going to know it. And it's the same feeling that she's trying to evoke in you, that young people have created the exercise with her to say that's how it feels. It feels like you're holding on to something and you're trying to decide and judge who's going to be the safest person to give that information to. So you might be that person, but you might not be, and that's okay, as long as you're laying the groundwork for the next person. So let's keep going. Let's start with a case. So this is where it gets a little bit interactive, hopefully, if people are keen. I don't mind, there's a small group, so if you want to shout out, that's fine. If you want to pop it in the chat, that's fine. Casey's a 15-year-old, she attends clinic. with a history of weakness and palpitations. The GP referral is that she's been increasingly tired. Mum couldn't attend with her. What are you going to do as you're preparing for clinic? Tell me some of the thoughts that you're having about this referral. This is based on a real case. Any old notes in the system? Yep, so you're going to have a little think, okay. So we had a look at some of the notes, and she's been seen about 2 years ago. She had a sort of slight weakness, but that seemed to improve. Did the GP give any other clues? Unfortunately not. It's a very brief clinic letter. There was quite a bit of the consultation written out, but nothing in the GP. Any blood results? Not recently, but yeah, there were some blood results from before. She's had sort of borderline low hemoglobin, but nothing major. Urine pregnancy test we've got coming up. Very good. You're thinking very nicely in adolescence. Yeah, so could be something going on with that. Chaperone, interesting. So thinking about if she's come in, she's not with her mum, so you don't have a natural chaperone for some of this examination potentially, and do you need to include someone? Would you see her is a question I wanted to ask as well. You know, she's not come with a mum to your clinic. Are you happy to see her? Check visits to other departments. Yep. Has she been known anywhere else? I'm hopeful that everybody on the chat would feel comfortable to see her. Basically, she's arrived on her own. There's a difference between the kind of consent and Gillick competence that we talk about. So it's about ability, not just an age. The fact she's brought herself to the appointment is probably indicative of somebody who can organise themselves quite well, and she can make the consent. You'd see her with a chaperone or a staff member. Yeah, I think that's fine if you feel that that being completely on her own is a little bit uncomfortable. But she is 15. She's going to be seeing adult consultants, you know, soon enough, her adult colleagues. So I'd be comfortable to see her on her own. Knowing the difference between Fraser guidelines and Gillick competence. So Fraser is really looking at focusing on contraception and sexual advice. It came out of a situation where a girl was given oral contraception and contraceptive advice without parental knowledge, whereas Gillick competency is more the principle of applying the capacity consent. It's just people get confused about that quite a bit. But basically, if you can't remember all the differences between Gillick and Fraser, what you really want to think about is you want to involve the young person in their decisions, but you need to judge on a case-by-case basis. Are they able to take in and retain the information and make a balanced choice with you? You can be deemed to have capacity to provide treatment. You can't force the young person to tell the parents. You can protect the young person if they're going to continue to engage in sexual activity, then on balance you can treat, and you can treat if their physical or mental health is going to be at risk. And the best interest of the young person, if the parents are not involved, then it's absolutely fine for you to proceed with treatment decisions without the young person having to tell their parents. I've had quite a few situations in A&E, I'm sure everybody's familiar with these, where young people have come in and said, I really don't want you to tell my mum that, but I think I might be pregnant, or I really don't want my mum to find out that I've been having these symptoms because she'll be really worried about me. And you can't force people to tell their parents, but you can have that kind of therapeutic discussion around why are they not wanting to. And it's not always because they want to be subversive about it, because they want to do something differently or naughty. It's often about protecting their parent, and that their parent has, you know, additional needs, or that they may be a young carer for the rest of their family. And I've had that very recently, and that's quite hard when a young person felt that they were really letting their family down because they've had to be admitted to hospital because they're a young carer at home. So it's thinking about it in a slightly lateral way. So this case continues. You did see her, you decided that that was fine, and you had a chaperone or not, and you found out that she's got asthma, pretty well controlled on an inhaler, and she uses salbutamol as she needs to. She's got normal neurological examination, so this weakness doesn't seem to be persistent. She's got some, so she's got some observations which are normal. She wants to discuss her asthma treatment at length, and she mentions that she falls asleep in class and thinks she might have narcolepsy. So just as you're wrapping up your discussion, she's read about this online and she's really worried about it. So what are you going to do next? Find out about sleep hygiene, yeah. So that's a really good shout, and that's basically what we did. So I did a heads assessment and I wanted to get to the sleep, but I thought let's start at the beginning. So she lives with mum and dad, 12-year-old sibling, got their own room. You can read through, likes art, some bullying, but that's been improved. She feels a bit concerned about exams. Eating is okay. She wants to lose weight, but it's not overly fussed. She's not really got any pervasive problems about her body image. She enjoys meeting friends. Her activities are kind of appropriate, with them drinking occasionally with friends, but not smoking or vaping. No drug use. She's experimenting a little bit with her alcohol intake. She does have a partner. They're having sex and using barrier protection. She's got no suicidal ideation or self-harm, and she's in bed around about 1 to 2 a.m. every night, and she's got to wake up a bit early in the morning for school. She normally has a nap between 5 and 6 when she gets in from school. So with that history, you've got your 20 minutes to see her in clinic. What are you going to tackle, and how are you going to do that? What do you want to focus in on? Get a history about her day-to-day activities. Yeah, absolutely. What's your approach to sleep? Yeah, it's an opportunity to educate about sleep. Do you have a preference over what you go for? Well, I think what I did with her was that I discussed sleep. I thought we'll use this as a therapeutic consultation, which is a kind of term around not just taking the history and getting all the information, but actually using it as an opportunity to highlight. And why is the sleep pattern is really important. So she was staying on her phone until quite late. She was really worried about her exams, so she was doing a lot of studying into the evenings. Because she was having this big afternoon nap when she got home from school, she was then kind of trying to make up for her time with her homework into later into the night, and then that was just pushing back when she would eat and when she would sleep. So that's great. You're sitting there in clinic and you think you just need to be in bed earlier, but that's not really the easiest thing to do. Bringing your bedtime forward when there's all these things to fit in. So what we did was I kind of wanted to find out from her, changed her name for the purposes of this, but where is she now? What's happening now? Where does she want to be? Where would be good enough? It's quite a nice model to use. And what would you be doing if you were one step closer? So finding out from her what she would be doing. So she said she wanted to not have naps in the day, which is really useful. And I think it's about acknowledging that she is in her teenage years, so she is going to probably need a bit more sleep than she was needing a few years ago. We know that there's this kind of elongation of your sleep requirements in your adolescent years, which when we understand how much the brain is changing and you're growing and the physiology is changing, it's no wonder that you need to sleep more. That's why babies sleep so much, right? Because they're doing all that growth and development. So acknowledging that she might need to sleep for longer, but trying to avoid that sleep being in the daytime when it gets in the way of the activities that she needs to do. So she focused quite well on wanting to cut out daytime naps. And I think finding one thing and then another thing and giving a stepwise progression is really useful. So either cutting out the daytime naps first or going to bed earlier first, you know, rather than trying to do it all at once and really getting it into bite-sized chunks. Where I work at the Adelina, we obviously have got fantastic support with Mike Farquhar and our brilliant sleep physicians here. So for this young person, the tricky bit for her was understanding that she wasn't really getting a good enough sleep. She felt that, you know, going to bed at 2 gave her, you know, enough sleep most nights because she could get about 4 or 5 hours. But trying to show her that the quality of the sleep she was getting was really something that we got a bit stuck on. So I'm lucky enough to have this the ability to refer and get this heptography, where you get a monitoring using a watch of the sleep pattern. And I was able to show her that actually she was really not getting a very good quality or a very good length of sleep in the end. But you don't need to have a fancy watch on that to do that. But this case was a little bit additionally tricky for other reasons. So yeah, sleep history is really important. You want to ask about onset, staying asleep, routine before sleep, what happens when you wake up in the morning, are you kind of using an alarm every day, or do you wake up naturally? And then resetting sleep. So if you have a period of time where the young person is so sleep disturbed that they're just not really getting to school at all, then what's quite helpful is to just have a period where you see what time you go to bed every single night at the same time, and you see how long you sleep for. And that will start to normalize within about 10 to 14 days to your normal sleep pattern, and it will tell you how much sleep you have. If it's completely disordered and you're kind of reversed and you've almost gone into a jet lag situation, then it's really important to think about, is it easier to bring the sleep time backwards, which makes you feel worse, or actually to reverse cycle going forward, so making the sleep 4 hours later every day. So instead of going to bed at 1 or 2, you tell her to go to bed at 6 in the morning. And young people usually think that's going to be quite good fun, but actually they have to anchor their sleep back again. And I can talk about that at the end if people are interested. Ask for some suggestions about how to do it. Ask, easier to have success if she feels empowered. Absolutely. So I think if you're talking about sleep in adolescence, you want to give as much control of it over to the young person as you can. And I think we all are guilty of taking phones into the evening and looking at blue light later than we should be, but everybody in the family has to model the same behaviour, and that's often a win if you say everybody's phone has to stay in the hall, and let you know, and an hour before everybody's bedtime we would advise that. So sometimes you can get a lot of the younger kids particularly on board if everybody in the family is being asked to do the same thing. And these websites are really helpful. So Young Minds is one that I recommend in almost all my adolescent clinic letters, because it's got a little bit of everything in it, a bit about mental health, sleep, anxiety, bullying, medications. It's a really nicely designed and put together website. It's also got a 24-hour helpline for parents as well as young people. So it's a really useful resource to have. And then the NHS website's got some great sleep resources and kind of sleep hygiene ideas. What was tricky in this case, and I just wanted to share some reflections with you on that, is that we had to move to virtual consultations for this young person, which were tricky but actually really useful, because by the time we moved to them, Katie, as I've called her here, was able to take calls herself. So she would answer the phone and we'd have a conversation, and she was able to tell me how she'd gotten on. And she was actually very happy doing it that way. Did not want to use video, but happy with the telephone consultation. Unfortunately, with COVID, we've been really close just before the pandemic of getting her into a really healthy sleep pattern, and then it just worsened. She had no routine, no school, apart, initially, and then some schoolwork that started to come through, and her sleep really reversed quite poorly. So we've made a referral to psychology for some additional sleep support, and a school counsellor to help manage that, because that's somewhere where she feels she gets a bit of support. And I'm continuing to follow her up, so we'll see. The only problem I've got is she's going to be 16 in 6 months. So this is another issue that comes out in common presentations, is that you've got this kind of race against time with young people to get them seen, and where do they go next. So what do you think about the kind of next steps, and what's been your experience of transitioning into adult services? What age groups do you see in where you work? And I like this explanation of what being an adult is, that we have to accomplish a mundane but necessary tasks. But yes, so we know that moving into adult services, we call it transition of services, and it can start really early with introductions to how people transition, by just seeing you on your own, or getting used to making their own appointments, or getting all the way up to bringing themselves to an appointment, or actually calling and asking for additional support or self-managing a condition. Remember, you're seeing them for, you know, one snapshot of probably about 20 minutes in an otherwise everyday life cycle. And I think I've heard lots of young people talk about that they manage all the time, and we see them for this short amount of time. So yeah, most specialties transition around about the age of 18, some at 16 if you've not been referred in before and are not in full-time education. There's been lots of discussions about transition to adult services. There's a really great toolkit developed in the north of England where they had a look at what was associated with better outcomes, what was not really having any evidence. And it's some of it's common sense, but some of it's a bit surprising. So meeting the adult team before transfer really helps with the outcomes post that. Promotion of young people's confidence in managing their health condition is really helpful. And appropriate parental involvement. So that's appropriate for the young person, not for us, not to make us feel comfortable that mum and dad know everything that's going on or that they're not in the room at all, but whatever is most comfortable for that young person. But what's really interesting is that really there's not that much evidence for having transition plans or age-banded clinics or services in the way that I would have expected them to be. The one caveat to that, I would say, is that this research has come out very recently with Dougal Hargreaves and his group around linking paediatric care outcomes with their adult health. And it's a really interesting article actually, because it looks at death rates among epilepsy patients before and after transfer from paediatric to adult care. And it's based on the ranking of the paediatric care that they received. So if you look at this, you can see the epilepsy unit performance is scaled as either good, moderate or poor. And then you've got deaths pre-transition and deaths post-transition. Now the deaths pre-transition for poor, moderate and good, although there's a little bit of discrepancy between them, are all pretty similar really. But interestingly, the good service that you've received in the paediatric centres, your deaths post-transition can continue to be in the same kind of 2.25%, whereas for those who are in a moderate service or a poor service, so those are ones that are not particularly linked to their adult services and don't have much in the way of transition planning, as defined by the team that did the research, actually have a much higher deaths of post-transition, which was taking into account the service provision from the adult service. So we do have a responsibility, I think, for taking that on board and realising that the service that you're providing right now, whilst you may not think that you're seeing a big difference between child to child, is actually potentially having a massive impact on their future outcomes. So be proud of what you do and think about how you support these young people getting transitioned into adult care. And that's where I come to you being a trainee and how much influence do you have? Well, I think you've got lots of influence. How you see young people and families is entirely down to you. So, you know, you can be a real advocate for these young people. Building a history and rapport is something that, you know, it takes time to ask heads confidently and to have that conversation. It doesn't always flow brilliantly, and you sometimes need to have lots of different ways and skill set to be able to make those conversations happen. And even, you know, people who think that they're really good at it are sometimes not the right person for that young person, and that's okay. Acknowledging that, but realizing when you maybe need to swap out with a colleague is a really important, insightful way of practicing medicine. You can be a role model for others. You are really well placed as a trainee or as a junior doctor to kind of see what in the service needs to alter and change, and actually being kind of there regularly enough to make those changes a bit more consistent. And you're considering the investigation. So a lot of young people that come in through clinic could be investigated, you know, from top to toe. They've got a lot of complicated different symptoms, and I think Terry Seagull talked about that at the beginning of the week around some of the kind of more complicated symptoms in those with chronic fatigue and POTS and chronic pain, who could be really, you know, investigated with multiple layers. But actually there's something about holding and containing and being comfortable that you've thought about the red flags, you've thought, okay, they've got abdominal pain, what are the things I need to be looking for, my history and examination. Okay, they're having regular headaches. Do I have any red flags for brain tumours? And actually thinking, okay, have I investigated? Am I happy with that level of risk? Do we need to think about this a bit more holistically again now? And you can definitely do that as a trainee. We've got a little bit of time, so I'm going to go through this second case. So this is a 15-year-old boy attending regularly with lethargy and headaches. So what are you thinking about from that? That's the extent of the referral that we had for this boy. Anything that you're worried about, anything that you want to rule in, rule out? Sleep, mental health problems, yeah. What's contributing to this lethargy? Brain tumour, yeah, I think that's really high on your list, isn't it? You see headache, that's what I think about in clinic. Growth, yeah. Red flags, yeah, all of this, perfect. So you're thinking info on the system already. What do we know? Do I have any previous information? Is there something about this that's going to make me think I need to do urgent investigations? So yeah, we were preparing for all that. He lives with mum and brother, in contact with dad regularly, doesn't really enjoy school, too tired to enjoy it, likes gaming, weighs 86 kilos, he's 15, he's got some inflamed acne on his face and his back. These are his blood investigations. What are you thinking that you want to pick out from those results? Weight, yeah. So we would need to do that. He's overweight, even without the endocrine features. Exactly. You've been listening to Hung-Lee's talk. Low vitamin D, absolutely. So that could be causing some of this lethargy and joint pains, bones and groans. Brilliant. Well done. Sedentary, not getting out enough. Good. Yeah. Likes gaming, sort of not doing a huge amount of kind of active stuff. I don't think the Nintendo Wii quite took off as we'd hoped to keep everybody active. So yeah, he's just sitting a lot of the time and probably got really poor sleep, right? So we have a little bit of a chat about all of that, and I agree. So he didn't have any red flags, and his examination was normal, neurological examination, but his weight, he was overweight, and he did have this acne. So if you were going to hone in on treating the acne, which we often don't treat, which for him, when we were talking, was a real source of sadness for him when we talked about his mood in the heads assessment. And it wasn't really the thing that I was focused at all on. I was really thinking, gosh, his weight is the issue. He's really lethargic. He's really tired. If he could lose the weight and I could help him with that, then that would be great. But for him, the acne was really bringing him down. So, well, how do you treat? What are your treatment options for acne? How confident are you to kind of start prescribing? Lifestyle changes, yeah. So diet, sleep, healthy eating, all useful. This is my hints and tips basically. This is from multiple talks from different dermatologists. This is from me scouring different guidelines to come up with something that I use. So avoid over cleaning the skin, and that's classically what he was doing. So he wasn't sitting there kind of conservative, not doing anything. He was actually really scrubbing the skin to try and get it clean, and that can cause worsening of the irritation, and that's really important to remember. If it's mild to moderate, you can use a topical benzoyl peroxide. You get kind of topical treatments that can be popped on. You can also use topical antibiotics. You always need to prescribe that in combination with benzoyl peroxide if using the topical antibiotics. So just to remember that. There are other things like topical retinoid, but they're contraindicated in pregnancy and breastfeeding and important to remember. The thing that most people do is they start using this every day, and it can be a little bit harsh. That's what dermatologists have told me. So actually, what I usually do is I say start using the benzoyl peroxide or the topical clindamycin and benzoyl peroxide once or twice a week, the first couple of weeks. And then as you build it up, you can start getting it to daily if it's tolerated, and that's recommended. That's part of NICE guidelines actually, and it has worked really well. If it's not responding to that, then you can consider an oral antibiotic, but up to a maximum of 3 months management with oral antibiotics, or the combined oral contraceptive pill if appropriate. Particularly sort of Dianet was very good for skin, but it had a really bad rep around DVTs, and then it got kind of down-regulated because it was much better at treating hirsutism. So, but it used to be a really useful combined oral contraceptive. The important thing is that if they're not responding to 2 different types of antibiotic or they're scarring, then you want to make a referral to dermatology. So there are topical clindamycin, it's fine. You could use an oral macrolide, or you could use, you need to look at what, if there are any antibiotic allergy, obviously, then we need to think about that. The important things about acne referrals to dermatology is if it's a severe variant, so these 2, then you need to make an immediate referral, and I've put some details into the slides for later, so you can look up what those are. If there's visible scarring or psychological distress, or you're not sure why the acne is quite so bad, then you need to refer to dermatology. And if there's a lack of response in about 3 months to stepwise treatment, then you should refer to dermatology. And I've found most dermatologists are pretty accepting of these referrals, and it's really thinking about it. So we did manage the acne, and he managed actually with some oral antibiotic, but then had to get a referral because he had some deep scarring across his back, but not to the extent of being an acne variant. But then we had to deal with the obesity, and we talked about that this afternoon with Steph, that this is an escalation problem. This is kind of a chart showing a really depressing chart of kind of the number of children diagnosed as obese between 16 and 24 over 2 time periods. And this is about kind of the lack of physical activity, which we went into today. My hints and tips around obesity are take a full history, understand what diet the young person is having, what is their daily intake, and what is their activity level. Sometimes reducing fizzy drinks, if they're heavily sugar content, is a kind of quick win, and reducing the number of fluids, because what I find a lot is that young people are actually drinking fizzy carbonated drinks instead of water, so they're having like 2 litres of Coke a day, and if you can even convert that to something a bit less sugar highs, then that can often help with other things like acne as well. And just make sure you do the basics: weight gain, thinking about your endocrine problems, and don't forget some of the kind of social prescribing you can do around Weight Watchers. So if you're over 13 but under 18, you can go to Weight Watchers with a letter from your GP or doctor and an adult. So if you think that might be helpful, that is opposite there. I'm going to come to the end of this here and have a little bit of time for your questions, because we talked a bit about mental health and CAMS. These are all additional ones that we can go through, but these are my hints and tips. Don't assume, just ask. Try to balance investigations for therapy with this kind of therapeutic consultation, and remember that you've got a yield of 1 in 3, so you are going to need to think about what you might do with information that's shared with you from a young person. Update your knowledge on managing these common adolescent issues. We should know how to manage acne. We should know how to have a conversation about obesity and sleep, and also about kind of heavy periods, which is another area that we don't ask enough about. And if you start asking young people, you will find surprising answers to why people are not able to participate in sports or school or other things, because they're having to kind of contend with these really heavy periods, which are either more than 7 days in length, or you're having to change pads every 2 hours, which is by definition heavy menstrual bleeding. So do just remember about these common things that happen to our young people. This slide I just put in at the end because I always think there's a tendency to want to be this really cool sort of hip consultant who can talk to young people. I'm not that. I'm not cool. pretty geeky, and actually that's okay. They're not looking for me to be their friend. They just want someone professional, and that's what you hear back when you read through the RCPCH information. And one of the sort of activities that we put in your activity pack for this week to do as a kind of reflective exercise was having a look at the RCPCH young person's impression of your curriculum. So the progress curriculum for each curriculum and capability, they've asked young people from RCPCH and asked, what does that mean to you? And it's quite humbling when you read about it and you see that most of what they're asking you to look at and look into is actually helping them to navigate the system and helping them to get the information that they need, not just kind of spoon feeding it out. So I think we underestimate and try to oversell ourselves. We don't need to be this kind of level of cool to be able to be relatable to young people. Are there any other questions before we sign off? And I know that I'm really conscious of being respectful of the fact that you've given up your evening and this is your time. So if there's anything that you would like to ask, I'm more than happy to answer. There's so much we can talk about. I could talk about this topic forever. So if you do have questions, don't hesitate to get in touch. There's lots of information available, and we'll make these slides available with something. I think somebody may have asked about which antibiotics. I'll pop that into the slides and share them with you. But yeah, your topical clindamycin first line for acne. Any other burning questions? I want you all to feel totally super that you're going to be able to manage these young people. Just be yourself. That is my advice. Just be yourself, be curious, genuinely be interested in what they're going to answer, and then let them know that you've heard them. And I've just finished dictating my clinic from this afternoon, and I've done some letters directly to the young people. And that was another hint and tip that I got from someone else, and it's really good because I think it allows you to think about what language you use. So if there's anything else you want to ask, we'll hopefully do some more sessions. Good.